All right, so thanks for everybody for coming to our methods seminar. It's my pleasure to introduce Dr. Kevin Dombkowski. Dr. Dombkowski is a research professor with CHEAR at the University of Michigan. His background is in public health and information systems, and he has extensive experience with public health, clinical, and administrative data management systems. He has collaborated extensively on projects supported the Michigan Care Improvement Registry, or MICR, and has conducted MICR-based interventions to improve the timeliness of vaccinations through automated reminder and recall initiatives. He evaluates the data quality of bidirectional interoperability between CHEAR systems and immunization registries, and he also supports the data and analytic needs of the Flint registry. And with that, he's going to talk today about give us a little bit of an introduction to public health informatics. So welcome.
Well, thank you, folks. As soon as I get my board on the show on the road here. So thanks, Kyle, for that. And as I was asked to speak about public health informatics, huge topic. We're going to just break off a few kind of examples here today. So over the course of the next hour, I want to take a look, diving directly into public health registries as they support public health surveillance to incredibly important functions in public health. Throughout that, we're going to be talking about electronic interoperability, a term that Cal has already mentioned in his intro. And I'm going to define it now because you're going to hear me talk about it a lot. So interoperability, to me, is seamless electronic connections between two systems. Let's say an electronic health record system and a registry, an electronic laboratory system and a registry. That's what I'm talking about with respect to interoperability. We're going to see lots of examples today, but unfortunately, we have 1 hour. I would teach this in a 16-week semester, so we're going to just do a little scrunching here today. So if I can figure out how to control this. All right, so we're going to start with a quick bit of history to bring us up to current day. Along the x-axis, we have time running from the 1950s, way back when, in the time of Elvis, to more or less present. On the y-axis, we have measles cases in the United States. You'll note that these are thousands of cases. So astonishingly, in the mid-50s, we're talking about well above 500,000 cases of measles in the United States each and every year, which is just astonishing to me. Well, enter the vaccination or the vaccine development in 1963 in the United States, and you don't need a zoom to see or to zoom in to see the free fall that occurred in the number of cases. So we went from about 500,000 a year in pretty short order to what appears to be no cases, almost stamped out. But that's not really true. We still had residual cases here, and I'm going to zoom in on this latter part of the chart here just to kind of change the scale a little bit. You'll note that this is no longer thousands. These are actual case counts. And so measles are still a thing in the United States, but happily the numbers are now being counted primarily in the dozens as opposed to hundreds of thousands. But every now and then we have, an outbreak. You may remember 2019, the year of the Disneyland fiasco, right? But again, we have really tamped down these number of cases to nearly nothing, but they're still with us. Well, so how did we do that? So that giant free fall I showed you is clearly a direct result of the development of an effective measles vaccine. But of course, with that came, going back to the 60s, this is the sort of dawn of the vaccination program in the United States. We had the need for provider education, parent education, and then public health had to roll up its sleeves. How are we going to get millions of doses into all those arms of children across the United States? And we got to keep on doing it, right? There's 10,000 babies born every day in the United States. So the cohort keeps on going. So we got to keep on going. It requires ongoing surveillance. It requires our outreach to those who are not properly vaccinated, either under-vaccinated or unvaccinated. And then we do evaluation just to keep on making sure that we can be as effective as possible. I highlighted these latter three because this is where we're going to spend a lot of our time today. This is where registries and other functions help us actually take that ball and run with it and keep those cases at an absolute minimum. So I'm going to come back to this chart here in just a second here, and you'll notice this little tiny blip in 1990. Well, it's actually not a tiny blip at all. The scale here sort of belies its importance. This is an outbreak which some folks in this room are very familiar with. Going back to 1989 through 91, we had a huge outbreak of measles. Just when we thought things were getting nice and quiet in the United States, we had 55,000 cases reported during that period with over 10,000 hospitalizations. And sadly, we had about more than 150 deaths in the United States. These are primarily children under 5. So this is an absolute public health disaster, a national embarrassment. It was horrible. What happened, though, is as we start to figure out, like, okay, well, who's been vaccinated, who's not? What are the vaccination rates in Detroit or Houston or whatever? We had no clue. It was terrible. We had very, very poor understanding of how to collect accurate surveillance information or accurate information on vaccinations in the United States. It revealed problems with records being scattered. Oh, well, I get some of my shots at the public health department, then I go to the pediatrician, da, da, da. This is a paper-based world. You know, we just had no way of connecting that. And it really led to our sort of the dawn of immunization registries. It underscored the importance that, hey, we need to do something vastly different and we need to do it quick. So this really got the national focus on immunization registries started. So I would say 1990s were sort of the dawn of immunization registries as we know them today. So you'll hear the term immunization information systems, same, it's really a different name for the same thing. These are population-based systems. They are typically, in the United States, I think probably universally, but let's say typically linked to birth certificate systems. Baby's born, within 3 to 5 days that birth is certified, it goes right automatically to the registry to start the registry. These are systems that are designed to, and this is a very lofty goal, folks, track all doses by all providers for all persons in one unified record. That's pretty tall, all right? So, and when we're talking about doses, I'll raise you on that one. It's not just doses administered, it's doses refused, right? Mm-hmm. Mom says like, no, thank you, not for my daughter, or, you know, I'll come back later, you know, and so those refusals are documented in the registries, as well as things like waivers, religious or philosophical waivers, that sort of thing. And then, of course, documented immunity. Oh, you know, she had varicella, so she doesn't need the chickenpox vaccine. That all is recorded in the registries that we have today. Just a quick schematic here. So these registries, this unified look, I mentioned it's population-based, but when we look at a population, could be a state, could be a city, could be an entire country for a national registry. But what we're talking about is all the health systems, let's say Michigan Medicine in our neck of the woods, or Trinity Health, whatever, all of the health systems, public health agencies, whether it be, you know, county health department, Washtenaw County, state of Michigan, private practices, you know, ABC Pediatrics, whomever. But another big player, which has really grown over the past few decades, retail pharmacies, right? There's huge, you know, right? Your COVID shot there, or RSV or whatever. So, you know, it's a big player these days. All of those players are connected to the registry to push those doses into this one unified record. So that's what makes it go. Well, there's a couple of other interesting and important features of immunization registry. One of them is a decision support function, which is actually really crucial. It's kind of the brains of the registry that takes all that information and says, guess what? If I know your date of birth and if I have your complete vaccination history, I can apply a national set of a set of national recommendations. Let's say in the form of the Advisory Committee on Immunization Practices, the ACIP recommendations, and I can say whether you're up to date or not for a given vaccine or a series of vaccines. So what's the benefit to public health? Well, not only can I assess an individual's vaccination status, I can take that collection and look at a population. It's an exact same arithmetic, basically, but now for the county of Washtenaw, or for that school, or for this state. So I can look at population level assessments of vaccination status. When I talk about assessing who's up to date, I always like to remind you that really in public health, we're oftentimes looking at the flip of that. Who's not up to date? How do we do the outreach? How do we get out there and keep those numbers of vaccinated persons high so that we can tamp down those cases as we go along, okay? So I apologize for the really crummy photocopy, but this is a 35-year-old thing. So this is an ancient vaccination schedule, which I put it up here just to show you, kind of go back to the kinder, gentler times when, when doctors used to make this stuff up. No, but they would basically memorize, the schedule was not difficult, and providers oftentimes did this right out of their head. They probably should have been carrying a reference, but they didn't necessarily do it accurately. But the point is, there was far fewer vaccines than we have today. It was a far simpler time, so this, this could be done, without very much reference, and providers oftentimes did. Well, usher in the modern era, and this is where we are today. So you recognize this as the current ACIP recommendations as published by the CDC. And you don't need to read the tiny type to know that it's complicated. That's the point here, is you can't do the math anymore in your head and say, okay, is this patient up to date or not? Or, oh, wait, they had stretched out some vaccinations over sort of their own schedule. Now they're sort of late for this. And like, what does she do for? What can we administer today? All those kinds of questions are very, very difficult to do. Certainly just not just intuiting it and doing it in your head, so to speak. So that is the decision support function of registries. They do the heavy lifting for us, and they will tell you at any point in time who's up to date, who's not, and what that patient is eligible for here as she presents herself in clinic. So that brings us to one of my favorite topics, the Michigan Care Improvement Registry, the MICR as we call it, was born way, way back in 1996. And as with many registries in the United States, all births in the state of Michigan are added to the registry directly from the birth registration process. So the state registrar certifies, and those go directly in the registry each and every morning. About 300 births go into MICR. The neat story about Michigan, there's a few states like it. We have not just a technically highly functional registry. It's a great product, but that's kind of just half of it. We have fantastic statutory requirements in the state that say, okay, guess what? All providers need to report all doses administered to children under 20 years of age. So that's a state law. Within 72 hours, you must report. So what does that give us? Epidemiologists, pay attention. We have denominators, everybody's going in, it's population-based, and we have the numerator events, all doses are going in. So what we have is a very, very complete picture of vaccination rates in the state of Michigan. A few other notes, all COVID doses for not just children, but adults are reported to the registry. And the interesting thing is in Michigan, our public health code says that although we must report for children, reporting for adults is authorized. In other words, when I go to the CVS and they get my flu shot or whatever, that can be reported to MICR, and it is. So that's also giving us the sort of other end of the population for adults as well. I should note in Michigan, we also have integrated into our statewide immunization registry results for newborn screening, blood lead testing, and newborn hearing screening results. So it's all in sort of this I guess.
I had a question about the required to report all COVID vaccine doses.
Mm-hmm.
I had thought, and you would know this much better than I do, but I thought that was actually a requirement from the CDC originally, but now states aren't required to report to the CDC. So in Michigan, is it in our public health code to report COVID vaccine doses?
That is my understanding,
okay.
but it did start out the way that you described it, which is the federal government can't actually tell us in our state or any state to do whatever, but they can say, guess what? If you want free vaccine, this is what you do.
Yeah.
Gary, please.
So the answer is yes, it is in the public health code, but more importantly, I just want everyone to know that Kevin was actually one of the people who designed this registry. It wasn't just that he worked on it, but his introduction was a little more modest, and that he was one of the real pioneers in developing these kinds of registries. And I just think it's important that we all in this room know that. So
thanks, Kevin.
But it was an interesting time because I like the history part of it, because we were kind of going from the dark ages. 1996. This is like the internet was like still just like being called it the World Wide Web, you know, I mean, come on. So, I mean, it's just a different era. We're a lot of paper, by the way. So, okay, just a few quick facts, you know, so, you know, in Michigan, we have about 9 million people. So the MICR registry has over 13 million persons in it at this point in time. We're approaching 200 million doses. So it's big, it's got lots of doses. Upwards of 7,500 providers are connected to the MICR, meaning they're either pushing doses in or using MICR to look at the vaccination status of persons or jurisdictions. And as I said earlier, we're around 300 babies born every day in the state. So those are added in every morning to the MICR registry, and about 10,000 doses are added each and every day. So I just wanted to transition from the immunization registry topic by pointing out that these registries exist in all the states in the United States. And if you're alert and with me, you'll note that it says 64, not 50, because there's actually more registries than one per state. We have some states, I'll just pick on Texas as an example. They have to do it their way. And so we have the state of Texas registry, and of course, San Antonio and Houston have their own registry. Other cities, Philly, New York City has a fantastic registry. So some municipalities have their own registries, and some of them are exceedingly excellent. But I leave you some references here for your future reading. Anything you want to know about immunization registries is here. So I'm just going to come back to this super briefly, because you know what? I pointed to all those doses being pushed into the immunization registry, but look, you got to pay attention. That's a double-headed arrow. So wait, what about the pulling out from the registry? So, okay, back to the dark ages for a moment. Well, this is not that long ago. I took this picture in 2009 in pediatric practice in Grand Rapids, but this is how all practices looked in that day. I mean, it was just like paper everywhere. So how do we do that exchange with paper? Well, think about it. So we're going to do an exchange. Well, I can photocopy something and give it to you, right? Or if we're going to get really fancy, I can fax it to you. That's what we're dealing with here. So my point is that this is actually the dawning. 2009 is when we had the major rollout of electronic health record systems in the United States. So we're still in a paper-based world, and we really did not have immunization registries integrated into our workflow. So you are in clinic and you're working with possibly an electronic health record system, and separate from that would be another computer logged into the MICR. And so it was like really not smooth, very clunky, to use a technical term, and it was just difficult. So it was very hard to get information out of MICR. A lot of people didn't do it. And so it just was not really smooth and well integrated. The workflow was not there. Well, enter in the modern era of electronic health record systems. And now I'm going to start really talking about interoperability, where, okay, so the arrows that I was sort of emphasizing at the beginning was electronic health records using that interoperability to push into the registry. But remember, it goes both ways. We can query a registry, and some really nifty things which are really important to public health. Registries can talk to each other. So state of Michigan registry can talk to Wisconsin or Ohio or Indiana and pull information on somebody who might have part of their record in Ohio and part of it in Michigan. This is all doable today. So what does that give us? Well, the key here is that we improve our data quality immensely in terms of the timeliness, completeness, and accuracy of that data by that sharing. The sharing, remember, interoperability, seamless, electronic, instantaneous. That's what we want. So it's very, very smooth, okay? How do we do it? Now we're getting to the good stuff. So, okay, some of you have heard me talk a lot about something called HL7, health level 7. Nobody says health level 7. So HL7, it's not just a Michigan thing. It's not a United States thing. It's an everywhere thing. This is an international standard. It's been around for more than 40 years, okay? This is a big deal. It's really taken off, though, with the advent of electronic health record systems in the United States. And I should say, before I forget, all the commercial EHRs in the United States speak HL7, all of them. It's just built in, okay? These are standardized messages for exchanging electronic data between systems, okay? Today, I'm going to talk a little bit about, or several examples, which are message-based HL7 messages. There's something called document-based messaging. I'll just I have a one slide overview of that. We don't have enough time to get into that, but just for your own reference, I have a link here to everything that you would want to know about HL7. But we're going to show some examples as we go along. Okay, so bear with me. This is an HL7 message. You don't need to really read all the fine detail, but you can probably see either on the screen at home or here in the back. The structure here are these segment headers, which I'll walk through in a moment, but this is like a glorified text message. It's got an interesting set of features though, because it's got these vertical bars and little delimiters, which are basically parsing it into fields, okay? So think of this thing here. This is one patient encounter, even though it wraps around like this. Think of this as like sort of like one row in a database or one row in a spreadsheet. This is one person's vaccination record being reported. Here's how it goes. This message header says, hey, look, this is a VXU message. This is a vaccination update message. I'm pushing a vaccination into the registry. It's for this patient, little Johnny Harris, and next of kin. This is either a parent or guardian, and then we get to the good stuff. So the RXA is the administration record that says, hey, look, today, here's the CPT code for an MMR that was administered. It reports all the details about that dose, the actual formulation of it, the presentation, the manufacturer, lot number, everything goes in with this record. And then there's also some additional good stuff. These OBX records say, oh, by the way, there's some other good things like this particular vaccine was paid for by the VFC program. Okay, so that's a publicly purchased vaccine here. So these records can go on and on. I mean, it can be hundreds and hundreds and hundreds of rows. Okay. You can also report historical stuff like, oh, mom pulls out a card that says, oh, we got so-and-so at the health department or whatever. And so that can be reported as well. So this structure sort of is the basic framework for HL7 messages, the text-based message. You're going to see several other examples as I work through our talk this morning, okay? So needless to say, those messages are packed with all sorts of great detail. Whatever you want to know, the who, what, when, where, it's all there, very, very detailed and a very rich source of information. And this is what drives the registries that I'll be talking, okay? So in recent years, we had a pandemic, you may remember. Well, those HL7 messages were absolutely crucial because you think about it, once we started getting vaccine into people, these real-time messages are flying from our MyChart system here, our Epic system, going directly into MICR. I go to the big house, I get my first shot. By the time they close that record in Epic, that record is already in MICR. It's there. It's just already there. So what we did is we helped the state of Michigan. Actually, for over 2 years, our team was pulling information out of MICR, those HL7 messages that were reported each and every day. We'd pull them the following morning, repackage them, and send them off to be included in that day's version of the COVID dashboard, which was a public-facing dashboard that was used throughout the pandemic. So that's what it gives us, is that real-time look. This is public health working for you, folks. You got information going directly out there, and then in this case, it was not only going to the public health agencies, but this is a public health facing function. I'm just leaving you with some other examples here, not that you need to get into this, but if you are interested, virtually all states have similar sorts of dashboards, but there's some good examples out there. So for those of you here, clinicians, you may not know it, but you folks send a lot of HL7 messages when you're on MyChart. You may not even realize it. I already showed you an example of vaccination updates, but things like, patients admitted, transferred to the ICU, step down from the ICU, all those transitions are triggering HL7 messages, e-prescriptions, sending those out, lab orders, lab results. All of that is going by HL7 messages. Some of them are within our own system, but some of them are leaving our system when we prescribe to, Walgreens or, wherever, the Meyer pharmacy. So those are leaving our system and then being sent out. There's over 100 different types of HL7 messages. We'll cover a few of them here this morning, but I just want you to know that these are prevalent in everything we do with electronic health record systems. Now, you may be asking at this point, Gee, Kevin, where do those messages go when they're sent? Well, I'm glad you asked that question because we're going to have sort of a one-slide tutorial on health information exchange. It's usually a 3-hour lecture, but here we go. So this is the Michigan Health Information Network, better known as the MyHIN system. It's a good example of a statewide health information exchange. All states in the United States have something similar to this, or not exactly the same, but it's the same basic idea. So let's just walk through sort of the anatomy of this. It's sort of a spoke and a hub model, which says, okay, the hub is our system, our health information network, and all of the other stakeholders in the state, whether it be retail pharmacies, health systems, public health agencies, insurers, anybody who is a stakeholder in healthcare delivery or reimbursement is a potential user of MyHIN. But the interesting thing and important thing is, instead of having all of these players connected to each other independently, imagine, you know, all of the providers each have their own connection to all of the retail pharmacies. It would be a mess. You couldn't do it. So instead, we have this, as they call it, one and done. You know, University of Michigan, Michigan Medicine connects one time to MyHIN, and all of our clinics go through basically one connection to MyHIN. And MyHIN has one connection to all these other agencies. Let's say the Michigan Department of Health and Human Services. So when that COVID dose goes into my arm at the big house and they close my record in Epic and it flies from there out into MyHIN, it goes to, it's routed to MICR by way of the Michigan Department of Health and Human Services data hub, which is sort of like the electronic mailman sorting the mail. Oh, that's an immunization record. That's going into MICR. Yes, Gary.
Does MyHIN act just as a transit point, or are things retained in MyHIN?
Excellent question.
Thank you.
Excellent question, because a lot of people go, whoa, that's a lot of great data, right? They are an agnostic handoff service. It's just, they're just routing the mail.
They're a traffic cop.
They're routing the mail. That's all
Got
they
it.
do.
Okay, thanks.
Now, that's actually not entirely true because they serve as the, they provide governance. There's important,
No,
you know, right, the rules of the road, you know, what's okay and what's not, all that sort of thing. So they do all the, you know, the data use agreements and all that kind of stuff, but no data is retained. Just, you know, just other than, you know, counters, you know, like how many messages went through today, that kind of stuff.
Thank you.
Yeah, great question. So that's health information exchange in 3 minutes. All right, so I'm going to say just, a quick word about birth registries, just because they're an important example, but it's going to segue into an interesting other HL7 example in just a moment. But the important and interesting part about birth registry reporting is when we look at, and we will in a moment, at what is required for a birth to be reported, more than half of the information on moms and babies, it can come directly out of there to the EHR for those. So, you know, in the old days, we had, you know, clipboards and we were doing this with pencil and paper. Those days are gone to some extent. And there's initiatives underway, including, I believe, here at Michigan Medicine to enable interoperability to actually take that link between EHRs and directly connect to the vital record system in the state of Michigan. HL7 messaging is a integral part of those efforts, but there's a little twist to it, which I'll show you. So I know you can't read this, and I'm not expecting you to, but just this is the United States Standard Certificate of Birth. It hasn't changed in 20 years. Every state in the United States uses this framework for reporting. We'll just zoom through a few pieces and I'm going to kind of chunk that through. So as you might imagine, a birth certificate has a lot of information on the child and the mother. To some degree, dad, not so much, but then certifiers, which will include, you know, birthing hospital officials and that sort of thing. But, you know, lots of demographics on mom and lots of detail on mom's history, prior birth and the like, any sort of complications, all that sort of stuff. Baby, tons and tons of details on the baby. Well, all that stuff is in the electronic health record system. So we don't need to be having staff transcribe that onto a piece of paper to fax it into the state, although it is still done, by the way. So here's the one slide for something that probably is a several-hour lecture. So I'm just going to bring your attention to something called FHIR. FHIR is another standard. It's an HL7 standard, but it's different from what I have been showing you up to this point. It's different from what you'll see in the other examples. It's not simply a text-based thing. It is actually, it's a standard, so it defines how the information is going to be shared. It's the rules of the road, but it uses something far more sophisticated and powerful, which is something called application programming interfaces. You'll hear the term API. Think of it as a connection. It's a connection between systems. So when you pull out your phone and you're doing banking, or you're calling an Uber, or Instagram, or anything on your phone, when it is talking, that app is talking to the server, the mothership, whatever it is using an API. It's a connection that then allows those things to talk. FHIR takes advantage of that, saying, guess what? We don't have to just constrain ourselves to sending these little text messaging things. We can actually send this is sort of a simplification of it, but we're sending links, addresses, IP addresses. So then instead of just sending text, we can send things like radiology images, right? So we don't have to, like, if the image is not in there, it basically says, okay, it's going to go to this receiving system and it's going to reach into your system and pull out the electronic location of that radiology image. So anything can be sent by this, okay? That's what I want you to know, anything. So the complete medical record can be transmitted through this standard. This is potentially important for you health services researchers in the room who want to collect patient data for things like QI studies or surveillance. And so I just want you to be aware of this. I've included a couple tutorials here. CMS has a bunch of them. There's actually hours and hours of tutorials. I've included a couple, mercifully, there's a 5-minute tutorial here, so it just gives you the sort of the thumbnail sketch. But I would encourage you to just be aware of FHIR. It may help you in the future, okay? That's all I want to say about that.
You want us to play with FHIR?
I do, I do. But you know what? You're gonna need to enlist the help of folks who really know something about FHIR. It's complicated, and it's still evolving too. So, okay, let's talk a little bit about biosurveillance in our remaining time. We're gonna talk about reportable diseases and syndromic surveillance. If we have time, we'll talk a little bit about chronic disease surveillance, all using HL7. So, it doesn't take, much of a lapse of time before another, some safety alert pops up in terms of, let's say, some foodborne illness outbreak. Just a couple months ago, we had, as you're, I'm sure, well aware, the whole salmonella outbreak thing with the cantaloupes, right? So this is a big deal. I mean, it was hundreds of people taken ill by this, upward of 100 people, I think, were ultimately hospitalized, but we had deaths involved, and 32 states reporting cases. This is a big deal, recalls across the country. Like, how do we know that? Like, how does that, like, how do we actually, like, get that information? Do you ever wonder that? Well, if you do, this is your lucky day. So the United States has an excellent framework for notifiable disease surveillance. Our case surveillance is aimed at a high level. We're talking about persons diagnosed with a disease or condition that is of some serious health threat. Okay, and we'll talk about what those are here in a moment. So it's something of public health consequence that we want to report. We have a great system in the United States. Reportable diseases are those that are determined by each state. So just as an aside, public health law in the United States is a state thing. Okay, so each state has their own law. CDC can't tell us to do anything. Take that, CDC. But they can encourage us by giving us lots of money. That's how this works. So reportable cases are determined by each state, but the reporting is actually supported by CDC as long as states actually do it in a standardized way. It's required by law, and this is a detailed person-by-person listing. Who had pertussis, names and faces. All of these cases are identifiable and reported to the Michigan Department of Health and Human Services. Slightly different would be notifiable diseases. Notifiable diseases are higher, not higher level. It's actually case level, but it's de-identified. Those are the ones that get bubbled up to the CDC so that we can actually look at across states and see things like this, like, oh, during the October and November timeframe, week to week, here's how all these salmonella cases are rolling out from week to week, and oh my gosh, look which state. This is coming from that system of notifiable disease reporting by states. Now, the notifiable diseases and reportable diseases, I'm going to say, are largely the same in Michigan. They could be identical, but anyway, we'll see those in just a moment. But I just want you to know that that framework exists. So how does that work? Well, in Michigan, all providers, labs, and hospitals are required by law. Again, it's a Michigan state law that says, these infectious diseases, which I'll reveal in another slide, must be reported to the state health department. So the big deal there is, of course, these are identified. Local health departments has to investigate each and every one of those cases. Okay, so salmonella, Jane Doe had salmonella. We're gonna actually do an individual case report on Jane Doe. So this is supported by the Michigan Disease Surveillance System. It's used by labs, healthcare providers, and health departments across the state of Michigan, as well as the Michigan Department of Health and Human Services. So I know you can't read this, but I have a link to it. This is a long, long list of 100-some conditions. Most of these are infectious diseases, not all of them. Some of them are foodborne. There's other ones, though, things like carbon monoxide poisoning and blood lead tests and stuff like that. So these are other reportable events that Michigan is deemed to be thou shalt report. So if you're a lab or health care provider, you've got to report. Cancer is also one of them. So these positive lab results and admissions for these conditions are reported using HL7 messaging. So let's go back to our old friend. This is the text-based version, as you recognize. Same setup as the message I showed you for vaccinations. Here's our message header, but oops, here, this is different. This is an observation result being reported. And what is being reported? Well, it's being reported by this hospital from this lab. A laboratory has reported a pathology result. Here is the test that was run, and then the result, which shows a positive pertussis case being reported. These are the messages that are being sent up into the Michigan Disease Surveillance System. So these are real time coming from laboratories. So I said it was EHRs in interoperability as well as electronic laboratory systems. Same deal. They're sending these HL7 messages directly to our Michigan Disease Surveillance System in more or less real time. Okay, now we're going to talk about something really cool. Not that that's not cool, but this is even cooler. Syndromic surveillance is trying to take that and sort of even move the clock back further to sort of nip that in the bud, so to speak. What it's aimed at is collecting and monitoring even these cases in their pre-diagnostic phase. We don't even have a diagnosis. We don't know it's salmonella. We have vomiting and diarrhea. That's what we have. So that's where this goes. It moves it back. So it allows public health officials to understand what's going on and investigate trends as these outbreaks are occurring and really symptoms are presenting to emergency departments across the state. It's also used, as I said, for some other conditions, carbon monoxide poisoning and things like heat-related illness and so forth. So here's how it works. Patient walks into the ER, they collect basic information, and they are admitted to the ER and with a chief complaint. Well, at that moment, there goes an HL7 message. When you are registered anywhere in any hospital, when that message, when that admission is completed, I have now given them all my demographic information. There's an HL7 message that says this guy is in the ER, and so that message is actually sent at that instant through MyHIN. So it just went into MyHIN and it went through that data hub and it went into the Michigan Department of Health and Human Services and it went into the syndromic surveillance system. Yes.
What triggers these messages so that to go into the system so that it's identifying like the right information to send?
Okay, that's a good question. For each one of these types of messages, there's something called an implementation guide. So it's basically the framework that says when you're reporting HL7 message for disease, for immunizations, for whatever, there's a separate different specification that says this is what is reported. And then here at University of Michigan, our HITS people behind the scenes will have set up that implementation guide that says, this comes from here in my chart, that comes from there. They're basically setting up a framework for this kind of reporting. After it's set up, nobody ever has to worry about it again. Okay, it's a great question. So HL7 messages sent through my hand. That chief complaint, excuse me, is classified into a syndromic surveillance category, which then says, okay, we don't know the diagnosis yet, but what we do know is this is some gastro related thing. So that instance of diarrhea and vomiting, thank you very much. How did you know I moved that? Is put into a syndromic category. And what we do is then start looking at these, there's algorithms running 365 days a year, 24/7, looking for unusual aberrations of, wow, look at that. 300 people went to the hospital for diarrhea and vomiting. That's kind of weird. So we're looking for those kinds of peaks that are very, very unusual. That's what the syndromic surveillance system does. So here in Michigan, we have the Michigan Syndromic Surveillance System, which receives information from all of the emergency departments in the state of Michigan, and as well as urgent care facilities. We're talking about something like 15,000 messages per day entering the system. And these are a slightly different type of message. I'll show you in just a moment. It's an important message type. It's called admission, discharge, and transfer. It's actually the most common of all the HL7 messages being sent. They're sent every time a patient moves from the ER to to the ICU, or from ICU to anywhere else. Any one of those movements by a patient are triggering ADT messages. And so as these and all of those, each and every one of those ADT messages at University of Michigan and every other hospital in the state of Michigan, all of those are going through my hand every instant. Every instant they're going through, and my hand sends them on to the Michigan Department of Health and Human Services. And then our systems, things like the syndromic surveillance system, decide whether that's important or not. No, already know about that. That's a duplicate. We don't care about that. And so all that stuff is going through. There's a lot of information going through each and every day. A lot of it's ignored. It's no big deal. Okay, the guy broke his ankle. We don't care about that. That's what's going on. Okay, so here's another view of the HL7 message, this time for the ADT message. So this says it's a discharge message. I can tell that because it says ADT 03. If it said A03, if it said A01, it would have been the admission record, but it's the same basic structure. There's patient information. There's actual information about the patient admission and discharge, because this is an actual discharge record. If it was a A01, it would be the admission. So some of this information wouldn't be there. There would not be a discharge date, and there may not be a diagnosis. All right. But interestingly, here you get down here, and here's the chief complaint. That's what's driving this system, is it's picking up those chief complaints and actually categorizing complaints. Okay, yeah, Chairman.
These excuse me. These are look like text fields delimited.
Yeah.
Excuse me, is that free text in that chief complaint, or is that discrete data that's coded as text and put into the chief complaint?
Well, the honest answer is I don't know, because I feel like I've seen enough of them they look like they're standardized, but I bet it's semi-standardized. In other words, this is the way Michigan medicine does it.
Yeah.
And oh, by the way, Trinity does it completely differently and whatever. So those receiving systems have to be smart enough to sort out the wheat from the chaff, so to speak, and figure out, like, well, they didn't actually label it the same way, but it meant the same thing.
Yeah, the board intel pertussis was capitalized.
Yeah, that's sort of.
Yeah,
so
how do you, so some system has to actually make sense of that and aggregate the ones that are.
And say, guess what? These 4 different representations are actually all the same thing. Yeah, it's a great question. Yeah, Kyle.
So getting back to the federal state issue that you were kind of talking about before.
Yeah.
If this is all standardized kind of HL7 kind of language,
Yeah.
like the technical barriers to actually making a national version of any of these things are pretty minimal, right? It seems like it's a more of a political will thing. Is that because I think the ED does the CDC has a national syndromic surveillance system, right?
Yeah.
30 states, but it's all voluntary, right?
Well, it is, and so, but just to sort of expand on that, I sort of flippantly said this, but it's actually true. The CDC gets things done with states by giving states grants, and I mean large grants of money. It says, guess what? In Michigan, if you participate in this grant program for, let's just say, notifiable disease reporting, we have, I'll make up a number, $10 million for you this year to do ... But these are the specifications you will follow. That's how we sort of edge toward a national standard, because the CDC is imposing that by saying, if you want the money, you'll do it this way. It actually turned out to be a fantastic benefit for immunizations 25 years ago. They started doing this 25 years ago, and they basically edged into a national standard by the CDC saying, great, we're going to help states with the registries, but we're not going to have everybody doing everything willy-nilly. When you're recording data, you're going to record at least this core set. If Ohio or Indiana or Michigan want to do things in addition to that, that's your business. But if you collect this core set, CDC will give you money each year for this.
But there's still not even despite the national standard, there's still not a national registry for immunizations. And that's
Correct.
That's always a problem when you're dealing with patients across state lines.
Right. So, okay, so we're in a new era because there are new conversations occurring, which are actually kind of funny in my mind, because I've been around long enough to hear this. And I think, Gary, you might remember going back into the 90s when registries rolled out, and there was just, we are never going to have a national registry. It's kind of like this big brother thing where they're going to be all separate, whatever. Well, guess what? We have a pandemic and everybody's going, you know what we really need? We need a national registry. It's like, well, that is the funniest thing I've ever heard, because that's what came up like 30 years ago. And so it's like, that conversation is not over yet, right? But the standards, the technical part, that's easy. That's easy. And every state follows this same framework, every state. Yeah, so these, and whether it be for immunizations, notifiable diseases, it's all the same. So, yeah. Well, standards are a powerful thing. Yeah, Gary.
Or so the thing that's missing, I think, there is medications. Are those not part of that standardized, like that surveillance?
Medications for,
Like, go back one slide.
you're saying go
This
back, if I know how to
encounter-
do that.
Errors, yeah.
So for this encounter, there's diagnosis, there's chief complaint.
Mhm.
And so, but there's like, say, this influenza with pneumonia.
Yeah, what did they administer? In
Yeah,
other words, yeah, it supports that. This example message does not include that, but there, those kinds of additional pieces of information can be included.
but it's not part of the core.
That I can't tell you, because I don't have that memorized. I don't know what the implementation guide says, to tell you the truth. So it's a good question, but I don't know what's required.
Okay, thanks.
Okay, so all right. So time check. Okay, so our last example is going to be, I think, a really cool thing, which is a extension of what I just showed you. All right, so just a refresh here, that ADT message, which I just showed you, admission, discharge, transfer, it can carry a diagnosis code on it if one has been reported, let's say at the discharge, okay? Every single one of those, every single day, are sent through my hand, every instant of every day. There is a initiative underway called Chronicle, which is a chronic disease surveillance system, which is aimed at looking at real-time surveillance of chronic disease in the state of Michigan. It's a partnership between MDHHS and CDC. CDC's footing the bill here. And they use those ADT messages for a different purpose. They're already going through my hand every second of every day, and they're being used for syndromic surveillance and other purposes like that. But as I said, most of them are being ignored because it's not important. Well, guess what? When those messages go through and they carry a chronic disease diagnosis, there's actual value to that if you were doing chronic disease surveillance. So the aim here is to foster, a better and more thorough understanding of chronic disease in the state of Michigan, so we can be more effective at our outreach and management of those persons living with or support for persons living with chronic disease. So there's a pilot that's going on right now. It initially was aimed at stroke and hypertension. It's being fielded by Henry Ford and Hurley, and we are in the process of trying to get Michigan Medicine on board. Sarah Reeves and myself have been involved with those efforts to tried to get Michigan Medicine on board. That looks encouraging right now, because really there's no ask here other than a legal document. It's a data use agreement, basically, because we're already sending each and every day the information. Nothing changes. It's just repurposing that information for a different use. That's what the data use agreement needs to include. But it's going to cover asthma, heart disease, diabetes, kidney disease, and sickle cell disease. And I will, I guess, speak for Sarah's sickle cell surveillance efforts. This is a really important additional piece, which is, you know, in sickle cell disease, well, Sarah has a wonderful gold mine of information, starting with newborn screening. So all kids are screened for sickle cell disease. But our registry only goes back to what, 85 or what?
87.
87. So persons born before 87, or adults who moved, or persons who moved from another state, we don't actually know about sickle cell disease for those individuals. And so there are cases that are out there that we really don't know about. This is a method for actually finding those cases that otherwise would be invisible to the surveillance system. So, yeah.
Kevin, is the theory with the chronic disease surveillance registry, is the theory there that the population sizes, when you think about the individual chronic diseases, are so small, and so there's an opportunity to think about maybe some key processes or things like that where you can use for improvement? Or
I think that's the goal, but I think right now they're capitalizing on the fact that, guess what, we have this system in place where we can know this I mean, the marginal cost is pretty tiny here. So just speaking to asthma, for example, you know, we've done a lot over the years looking for asthma surveillance in the state of Michigan. Like, okay, let's look at Medicaid claims. So I set up a system with the state 20 years ago for Medicaid claim surveillance. Oh, Blue Cross Blue Shield, you're cobbling all this stuff together. Well, excuse me, it's good, but it's not perfect. This is getting at yet another way to say, guess what? There are other cases that we're clueless about. So it sort of fills in the missing game. That's the best I can say.
okay, yeah, because you think about like, yeah, and you think about like different chronic disease registries, right?
Yes,
And how when you try to mine into those chronic disease registries, you have small populations in, like, let's say Michigan for sickle cell, but then what does that look like across the state?
Yeah,
But then,
well, you know, lupus is a good example.
Yeah.
It's a tiny registry, but it's really hard to maintain. So you would actually have a continuous flow, depending on the accuracy of coding that's going into these messages, to pick up potential cases that were otherwise invisible. So that's the goal there. So, okay, so in our whirlwind tour of public health informatics, a lot of what's on this list are things that I didn't talk about and really can't talk about today, but I just want you to know that, you know, there's a big world out there in terms of other informatics systems, principally in the form of registries, which are really the backbone of public health. We did talk a little bit about screening, well, actually preventive services in the form of immunization registries, vital records we touched on, communicable disease we touched on. We didn't touch at all really on cancer. Cancer is a enormous, it's actually sort of the grandfather of registries in the United States. All cancers are reported in one way, shape, or form to registries. There's lots of different types of registries in the United States for cancer, and if you're interested, I'd encourage you to look into that, because different states have different levels of detail of what is reported there, but all those cancers are reported to ultimately to CDC as well. They're really important, by the way, in terms of understanding when cancer is diagnosed and the staging of the cancer at the time of diagnosis tells us a lot about our effectiveness of treatment also. So there's other registries out there that are near and dear to our heart, things like environmental exposure registries. I work with the Flint Registry, which is tracking persons potentially involved with potentially exposed to lead in the water in the municipal system in Flint. So we're maintaining that, or actually our team is helping with the outcomes analysis at this point in time for the Flint Registry. But there's other ones, if you're interested in sort of the mother of all environmental registries, it's the World Trade Center Registry, which was started following the 2001 terrorist attack in New York City. It's a life course registry. It'll be around forever. It'll outlive all of us. It's funded forever. And it has the most incredible detail in it, for persons exposed in any definition of the word exposure. Psychologically, just the most amazing detail. And that is really kind of, I think, really the gold standard for environmental registry. So anyway, but just to close, though, there's a lot of other registries that sort of go into the clinical medicine space, right? We have knees and hips and everything else, pacemakers where we put in people, all those are tracked, right? They all go into registries, and organ donors, transplants, blood donors, all that. These are all registers, right? So they're all around us in the work we do. All right. So there we have it, folks. In our limited time here, we actually did cover a lot of ground talking about public health registries and surveillance. And I hope I at least gave you a taste of how interoperability, remember that word, interoperability, EHRs and other systems, seamless, instantaneous connection to support public health. So with that, folks, I think I'm out of slide.